All right, well, let's get started. I know we have some competing events going on today with other programs that many of our members also participate in, but it looks like we have a good turnout. So let's get started. It's March, which is kind of incredible to believe that we are like 1 week away from that day last year when things just seemed to dramatically shift for the world. But I'm glad that we can all be with you, and can't believe we're coming up on a year of these joint calls where we, transformed our monthly policy call to also have this focus on COVID-19. General housekeeping, all lines will be in listen only mute. Please, if you're asking any questions via the chat box, make sure to send it to panelists and attendees so that everyone can see. And if you have any technical difficulties, email Jess Cohen. That's jcohen@amchip.org. So today I'll start with a policy update from AMCHP. Then we are joined by our partners at MCHB and CDC. And then we'll have a special presentation by some friends from the Institute of Women in Ethnic Studies. Oops. Oh, okay, let's see if I can go backwards. Olivia, can you? Yes, thank you. Okay. I got it. So FY22 appropriation season is upon us, even though, fiscal year 21 appropriations only finally got decided at the end of last year in December. But I wanted to share with you, first of all, our great new fact sheet. Shout out to Olivia, our health policy fellow, who helped us redesign our one-pager that we've been using for many years to make the case for the Title V Maternal and Child Health Block Grant. We're asking for $750 million this year. That's from AMCHP, and hope that other organizations that can do advocacy work will join us in this request. We, if you remember, ended up at 712.7 in FY21, and I just realized I need to fix that on this. But otherwise, if you need any materials or are looking to do any advocacy work on that, you can contact me directly. So we've talked about this a lot, both on our previous town halls as well as the recent Title V partnership TA meeting. The COVID relief package that's currently making its way through Congress is going through a process known as reconciliation. And that's really for the purpose of current rules, which make it so that only 50 votes are necessary to pass it through the Senate. Or a simple majority, but that would mean getting all 50 Democrats on board, plus having the vice president be tiebreaker if necessary. And that's to get around the filibuster for the Senate and their lovely, rules that those of us who worked in the House never understood had this process in place. So there was a very clear guidelines, their parameters that they had to remain within in order to make this bill fall under the rules of reconciliation, which meant they couldn't just put in any provision they wanted. So they had to send it back to each committee that was relevant with their guidelines of how much money they were allowed to spend and what would be considered relevant to pass through reconciliation in the Senate. Out of that came from the Ways and Means Committee an additional $150 million for the MCHB program, which is really exciting. That's the Maternal, Infant, and Early Childhood Home Visiting Program, of course. So that's 150 in supplemental funding for MCHB. This provision also allows uses that aren't always necessarily allowed within the MCHB program. So allowing, for example, buying products that could help both the families and home visitors acquire technology to be able to convert to telehealth visits. There's also an allowance in there for emergency supplies for enrolled families like formula, food, water, diapers and diapering supplies, and also a requirement to coordinate with diaper banks if you're going to be providing supplies that are like diapers and diapering supplies that would normally be supported and supplied by diaper banks. And over at Energy and Commerce, a lot of great provisions as well. Increased funding for the CDC for vaccination efforts, for diagnosing, tracing, and monitoring COVID-19, a $500 million in extra funds for the CDC to expand and maintain data surveillance and analytics. There's also funding to expand and sustain the public health workforce. And of course, these funds would be going through state, local, and territorial public health departments. It doesn't specify, maternal and child health or infectious disease. So that's something that I'm pretty sure that the states would have to figure out. But this does include, for support for everyone from contact tracers to community health workers to epidemiologists, and also supplies like PPE for those health workers. There's also $7.6 billion in an emergency connectivity fund. And I know this is really important as we both have, children who are still learning remotely, and then also, of course, the increase in telehealth services. Just making it allowable to provide telehealth services doesn't really do us any good unless the families and providers who are utilizing it have the connected devices and the Wi-Fi to provide it. There's also some extra money for Title X family planning and tribal health funding, tribal health programs. I also want to point out that there was a really exciting development on the Medicaid and CHIP front regarding postpartum Medicaid eligibility, something that we've been working on for a long time. This is really exciting. It isn't everything we wanted, of course, but it would allow states for 5 years to extend Medicaid and CHIP eligibility to women for 12 months postpartum, whereas previously many states would end Medicaid eligibility if you were only on Medicaid because you had been pregnant, that it would end after 60 days. So this is really exciting, and hopefully it will get passed by the Senate and signed into law, and then we can, move on to trying to get bigger and better support for that program as well. So the House was able to pass this bill, and they did so pretty much along party lines. Now it's over in the Senate, and the language was just released, I think, last night or this morning, and they're going to be considering it immediately, but it will take, at least a few days to get through it, most likely because of amendments and other voting rules in the Senate. But there have been some changes to the bill from when it was originally passed in the House. So that means whatever they do in the Senate will then have to go back to the House, and it's required to all be on the president's desk by March 14th. So that's the deadline we're working within. So now I'm going to turn it over to Jess Cohen to let you know about some great new products and resources from the Health Systems Transformation team.
Thanks, Amy. We have a few new resources, an event we thought may be of interest to those of you on the call. I'll share all of the links for these materials in the chat that I'm going to introduce. So first, you see our ACA special enrollment materials here. We've developed a fact sheet for how Title V professionals can support the special enrollment period, as well as an English and Spanish fact sheet for consumers that you might consider disseminating to those you serve. Next slide. We also partnered with Georgia Health Policy Center to develop an overview of Medicaid options for states to support MCH during COVID, which I know we've discussed frequently on this call, and this publication also includes 2 more state examples. Next slide. And lastly, we invite you all to join us for this upcoming coffee chat with AMCHP policy experts. It's an opportunity to hear from our team on a deep dive of federal policy under the new admin and implications for MCH. Thanks, Amy.
Great, thank you so much, Jess. And now I'm going to turn it over to Chris Dickton, the Acting Director of the Division of State and Community Health at the Maternal and Child Health Bureau. Thank you.
Thanks, Amy. Hi, everyone. My name is Christopher Dickton, and I'm representing the Bureau today to be able to provide the Maternal and Child Health Bureau's updates. Next slide. So last Friday, everyone on the MCH director's listserv received an email about the planned timeline and schedule for this year's block grant reviews schedule, as well as the dates that we've tied to this schedule this year. The decision to make a September 1st, 2021 date for submission recognizes the ongoing demands being placed on the state and local public health programs in addressing COVID-19 and how it responds to the differing needs of the states. So in consultation with HRSA's Grants Management Office, the decision was made to allow a rolling due date for submission of the 2022 MCH block grant application and the 2020 annual report with a deadline of September 1. The Title V information system will open up as planned on April 1st, and it will be available for each state to start its preparation of the application and annual reports. And you'll have the option to submit that block grant application and annual report anytime up through September 1st, 2021. Like last year, the reviews will be conducted virtually, and it'll run from the period of October to December 2021. Next slide. So here's a high-level view of the modified timeline. As mentioned, it'll be the September 1st deadline. During that period of time after September 1, MCHB will conduct an internal financial assurance and completeness review of each state's application annual report to make sure it's eligible to receive grant funding starting October 1, 2021. Again, during the period of time from October to December, we'll be meeting for our block grant meetings to receive where technical assistance will be offered and to review the applications and annual reports. Summary statements will be completed hopefully shortly thereafter and will be disseminated to states and jurisdictions, probably starting at the end of October and going to February. This timeline should seem very familiar. It's in line with what we have been doing this past year. I think one of the things that we needed a little bit more time was in the month of September and getting the materials prepped for the block grant review meetings in the fall. Next slide. So I'm going to follow up with something just shared in terms of a resource, and it's MCHB here. Really encouraging collaboration and partnership with your locals and with families and with the MCH populations in your state to participate in the special enrollment period. Next slide. You know, one of the things that we've looked at when we look at insurance and underinsurance is that there's been a startling trend over the last 3 years based on census data indicating an increase in uninsured children, where it's reached 4.4 million in 2019, which is about just under 6% of all children. This translates to 726,000 more children under the age of 19 without health insurance. And it just emphasizes the need to expand access to insurance is even more urgent than ever before. Next slide. We all agree that health insurance is essential for children to get the care that they need to grow and thrive. And of course, data indicates a strong connection between the well-being of children and their parents, and insurance has a great deal to do with that. You know, MCHB's programs promote the children's coverage by partnering with national, state, and local maternal and child health stakeholders. The MCHB programs, including the block, MCHB, and Healthy Start, we've all had performance measures and outcome measures related to insurance coverage and underin coverage and try to improve program impact. And so in 2019, for example, with the help of MCHB's provided services, the uninsurance rate among the children enrolled in the home visiting program was only 3%. Next slide. I think one of the things about the open enrollment that I'd really like to emphasize is use, you know, let's all partner together to try to get as many families enrolled that can be. One of the things that I want to emphasize here as I close out is upcoming important dates. Our ongoing Title V partnership meeting continues with the next one being March 18th. And we'll focus on the guiding principles behind the block, specifically looking at evidence-based programming and family and youth engaged practice. At the end of March, we'll meet again, and this will be the TVIS users webinar where we will go through the changes in the guidance from the revision that was implemented in January, and also looking at how that has impacted the changes in the information system itself. There'll be two different training sessions at the end of the month, one for experienced users, one for those that are not experienced with the system. April 1, TVS opens, and on the 15th, we'll continue the partnership meeting, focusing on the state action plans and how they're being implemented. And this time we'll also have a dedicated chat around the blueprint for change, looking at those, advancing the system of services for children and youth with special healthcare needs. So with that, that's the updates from HRSA. By all means, reach out. If there's any questions, feel free to put them in the chat box and we'll follow up. So I'll give it back to you, Amy. Thanks so much.
Thanks so much to you, Chris, for those updates. And now it's my pleasure to turn it over to Dr. Karen Remley from CDC's National Center on Birth Defects and Developmental Disabilities.
Thank you, Amy, and happy spring, everyone. I'm in Richmond, Virginia, and it's 60 degrees out and the sun is shining. So I hope all of you have some side of nice weather to enjoy on this gorgeous day. I wanted to start off just saying that I had the opportunity since the last time we talked to meet with our new director, Dr. Walensky, and I would say to you that she was very interested in issues around moms and babies, birth defects, critical congenital heart disease, developmental disabilities. Across the board, she was very engaged, very involved, and had a lot of questions. So I see her, I think, as you can imagine, her life right now is COVID, 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 COVID. But as we look to the future, I think she'll be an incredible partner and leader as we talk about these issues. And so now I want to transition and to give you a few new facts about pregnancy. There's a new study that came out March 1st in MedRx, the 4th version, about risk factors for illness severity among pregnant women with confirmed SARS-CoV-2 infection, surveillance for emerging threats to mothers and babies network. 20 states, local and territorial departments, March 29th through January 8th. So really a long period of time while we've had COVID. So this analysis was of 5,963 pregnant women with COVID-19, found that an age over 30 years, being Black, non-Hispanic race and ethnicity, occupation as a healthcare worker, and having underlying medical conditions were each individually associated with the risk of developing more severe illness from COVID-19. The risk of more severe illness increased as the number of underlying conditions a pregnant woman had increased. And this information may help pregnant women understand their risk for developing severe COVID-19 illness and inform targeted public health messaging for those particular groups. And I think that Wendy has already added in the chat box the link to that article. As we look at children and youth with special healthcare needs, I want to talk a little about that those children with disabilities usually require additional supports and adaptations for daily living. The COVID-19 pandemic has interrupted the routines and access to usual source of support for so many children. The long-term impact of those disruptions of routines and usual sources of support remains to be seen. None of us are surprised that emerging evidence suggests that parents of children with intellectual and developmental disabilities are concerned about the long-term impacts of the pandemic on their children's development, given those losses. A recent survey conducted by the National Institute for Early Education Research provides limited data on early identification and support of children aged 3 to 5 years of age with disabilities. The percent of children aged 3 to 5 years with an individualized education plan, or an IEP, declined from 9% in the spring to 7% in the fall of last year. CDC, through the Study to Explore Early Development, or SEED, Phase 3, which is a multi-site case control study of children with autism spectrum disorder, other developmental disabilities, and from the general population is collecting information on the impact of COVID-19 on services, behaviors, and health during 2020 to help inform public health strategies for young children aged 3 to 9 years and their families. There's also a need to support national data collection on children with disabilities so that we can better understand, prevent, and mitigate the effects of COVID-19 for this important population. We have incorporated information about children with disabilities in several COVID-19 related documents and web materials. And Wendy, I'm sure will once again be giving you some links in the chat box with that information. And then lastly, we have a Monday partner call is on engaging faith leaders to advance effective COVID-19 response, lessons learned through global domestic collaborations. And then some updates on vaccination. We are, as you all heard, I'm sure on the news, this weekend, the CDC ACIP first recommended the use of the third COVID-19 vaccine for people 18 and older. That's the Janssen or the Johnson & Johnson's vaccine. The recommendations of ACIP were accepted by the CDC director. So those vaccines are rolling out across the country right now. And on March 1st, the vaccine safety team presented an update on the latest vaccine safety data, including safety data on vaccination during pregnancy to that same group. And the key points can be found, I've got, it says slide 37, but I don't think I have slide 37. Do you have a link to that slide, Wendy, that we can put up? But if not, I'll get that to you, Amy. But what I would say is the key points about maternal vaccination safety is to date, we don't have any significant safety concerns that we've seen in the more than 30,000 people that have identified themselves as pregnant. So we continue to monitor that very closely. And then the last thing I'll say, some of you may have noticed that ACIP added to their language that people with intellectual disabilities, developmental disabilities, and the elderly frail are all individuals that as states make their plans for vaccination, they should consider unique and different ways to approach those populations that may be homebound or may have difficulty accessing vaccines either through pharmacies or through large vaccination events. And I will stop there and see if anybody has any questions and turn it back to you, Amy. Thank you.
Great, thank you so much. And hopefully everyone sees that Wendy has pasted the links in the chat. I know sometimes if I don't put the chat box up on a Zoom call, I don't even realize that people are putting things in there. So now I'm going to turn it over to my AMCHP colleague, Shaq Ballou, who's going to introduce our guest presenters today.
Thanks, Amy. Hi, everyone. I'm Shaq Ballou. Like Amy said, I'm a program analyst on the Women's and Infant Health team at AMCHP. And it is my pleasure to introduce Mushan Tarver from the Institute of Women and Ethnic Studies in New Orleans, and her colleague Shay Pounds, a birth worker in Louisiana. The Institute of Women and Ethnic Studies is one of the 10 inaugural grantees of the Safer Childbirth Cities initiative, which was founded by Martha Mothers, with the aim to support community-based and community-engaged organizations in the implementation of evidence-based interventions and approaches to reverse negative maternal health trends and tackle racial inequities and maternal health outcomes in our country. So over the past year, AMCHP has had the pleasure of working with the New Orleans team as part of our community of practice, in which we're supporting peer learning and relationship building among the grantees who are involved in the SEC. One of AMCHP's goals in hosting this community of practice is to uplift the work of these organizations involved in the initiative and facilitate alignment and connection with the Title V MCH department in their state. So Mushan and the IOS team have tremendous expertise in the areas of midwifery and doula care and the factors at play when families decide to have a home birth. And we are so excited to have them share this expertise with you today. So with that, I'll pass it over to you, Mushan.
Good afternoon, everyone. Hi, Shay.
Hi, Sister Mushan. Hi, everyone.
I'm going to get started.
Yes, I am Shay Pounds. I'm a student midwife, like she said, here in New Orleans, Louisiana, and I'm representing the midwifery population here today.
And I am Michonne Tarver. I am I'm a moonlighting doula, and recently had to work directly with Shay with a couple of home births. And also, but my full-time work, I am a MCH practitioner. I do a lot of research on infant and maternal mortality outcomes in this area. I'm an advocate of MCH. And at iWest, I am the program manager for maternal and child health. Next slide, please. So iWest, the Institute of Women in Ethnic Studies, has been around for 27 years now. It is a community-based organization, a research-based community organization, that is. We do a lot of research in these different program areas, but we also utilize evidence practices based off work done with the CDC and NIH. And the work that I do with the Midwifery program or with the MCH program is is one of the many programs at iWest. We do the work that we do, we make sure that we collaborate with different projects around the country and in our city. And for us, it's very important that any research that we do is not solely based on getting articles published, but we do it so that we can inform community practices. Next slide, please. So here I wanted to just lay out our MCH program, how it started in 2019. So as Shaq said, iWest, in partnership with the National Birth Equity Collaborative and Birthmark Doula Collective, received funding to be a safer childbirth city. And what we've done, and if you look at the layout of it, iWest is primarily responsible for utilizing mixed methods research. So we do quantitative research, but last year we did a lot of work with qualitative research where we were doing focus groups with people with lived experience, whether that was breastfeeding experience, childbirth complications, families who had children or infants in the NICU. We also interviewed midwives and OBs in our area. And so the purpose of this research was, and I'm going to go towards the bottom first, excuse me for being a little backwards. We wanted to utilize our information that we got from not only the people with lived experiences, but with the healthcare providers that we interview to find out what ways that healthcare providers can improve the practices. So our partner, National Birth Equity Collaborative, does this birth equity training. So the research that we got, we were able to provide to them to expound on their training. And in 2021, they are looking to do more trainings in our area to help with implicit bias, just really systemic racism in our area. And so looking at the top half of it, we utilize our training and we work with Birthmark Doula Collective, who's actually a collective of doulas, but they do doula training as well in partnership with Sister Midwife Productions. So we presented with their training, and this training that they're doing, or they piloted in 2020, was not only providing doula training, but also breastfeeding training for community members to develop this perinatal community health worker training. And our goal with this is to take this training to advocate with policymakers or lawmakers to get doulas reimbursed in our state. And we've been very successful with our efforts. We actually have a lawmaker that is going to present a bill this upcoming session to get doulas reimbursed in our area. Next slide, please.
This quote says, home births are natural, not something to fear. It's how everybody used to give birth. This spoke to me so much as a home birth midwife in training. I don't really use it in training. I usually just say home birth midwife because it really is how we used to give birth. Everybody that is here and that's on this call is a result of a home birth. And that's a little perspective that I like to give people, that hospitals are a new age thing. And we should definitely look into how home births can affect us moving forward, especially with situations like COVID-19, for example, and how the pandemic has impacted home birth in such a positive way. Next slide, please.
All right, let's look at home birth in the news. So let's think about it. It's been a year ago now that we all were impacted by COVID-19. And so in the news about a year ago, we as birth workers or as MCH professionals, and you as well, saw all of these news articles, and this came from around the world. You have one, Black women are turning to midwives to avoid COVID and feel careful. Pregnant moms scared of COVID-19 in hospitals need more home birth options. Why more moms are turning to midwives at home birth? So when we saw this information, we wanted to know what's going on in our community. So this is what we saw around the country, and they had a few articles that were released locally, but we wanted to hear directly from the people that we serve. So we reach out to our midwifery, our midwife contacts, our doula contacts, and we ask them to refer patients to us. And so we conducted in-depth interviews with families, so not just moms, dads as well, to learn from them why did they choose a home birth, and why did they feel that it was a safe option. So during this time, parents or families were scared. They were scared for the exposure of COVID to their family members or to themselves. They also was concerned about the decrease in support. Some hospital policies changed where you could not have everyone in the hospital or anyone that you liked in the hospital. You only can have one person at the hospital, and there was no change out. So once that person came in with you, they had to leave with you, or if they left, the mom was left alone. And for some families, this was a scary option, to be in the hospital during a time of vulnerable time in their lives. And we also heard during prenatal, it's still going on now, that during prenatal visits that the spouse or the partner may not go to those appointments with them. So parents were really concerned about this situation. And I know in our area, we had to advocate for doulas to be considered a part of the essential team, so that one person or two people that were invited to be a part of the birth, the doula was considered as that one person. So if a mom had a doula and she only could bring one person to the hospital, it would be her partner. And doulas have been shown, demonstrated scientifically, to improve birth outcomes. So parents or families were actually scared during this time. And so we conducted these interviews so that we can find more about what was going on with our patients. Next slide, please.
Here we see numbers, if you're a numbers person like me, around out-of-hospital births. Even before COVID, we can see a large increase in out-of-hospital birth, some in birth centers and at home. Not all of them occurred at home, but we can see that they were less likely to have population characteristics associated with poor pregnancy outcomes, which is important. We see a proportion of home births increased by 41%. That is a huge jump for home births. You can see that there was a decline from 1900 to 2004. That's a really long time. So when we're talking about a short amount of time, like the year of 2020, I'm pretty sure when those numbers come out, we'll see a great increase, maybe even, I think, around 2% of the number of births that happened outside of the hospital. Next slide, please. We also have here the environments for certified midwives and maternity care deserts. You can see like the little clusters of where these things happen. A maternity care desert is where you have to travel in order to, receive sufficient maternity care, or your hospital only has one OB or something like that. So that poses a large risk for rural populations where home birth midwifery is actually very popular for those reasons, because traveling 2 hours in active labor may not be, the best option for you. So here we see an example of that. Next slide, please. And here is more of the same. We see the distribution of obstetric providers. So you can definitely see clusters of where, there just aren't as many providers as we would like, giving the type of care that we would like. And you can also see the percentage of births down at the bottom occurring outside of the hospital by state. And if we were to look at those slides like side by side, you can see that some of the states where more births take place outside of the hospital, they actually have better maternal outcomes. Next slide, please.
And Shay, I just wanted to add, I was in a meeting yesterday and they were talking of when you look at those states, those southern states where you have lower numbers of certified nurse midwives, where you have those maternal deserts, that maternity care deserts, there was a direct correlation with poor birth outcomes or poor infant outcomes as well. So this is this workforce shortage or discrepancy shows that there is if we improve on these shortages, we actually improve on our MCH outcomes as well.
Absolutely.
So what do we do? So after we heard what was going on in the New Orleans area, what we decided to do is to expand on our qualitative research that we were doing to not only include childbirth and complications, but like I said before, adding home birth interviews to that. Something that happened for all of us, if we were working outside of the home, we had to increase usage or utilize personal protective equipment. So we did some fundraising in our areas to help local midwives get the personal protection equipment. Because there was an increase in requests for home births, we wanted to make sure that the people that we collaborate with were doing it in a safe manner and also had the resources that they needed. So because of this increase in hearing what families were saying in the home birth interviews, we decided to conduct a panel of midwives. And in this panel, locally, we had certified nurse midwives, we had certified professional midwives, all together talking about not only the increase in home births, but the pathway to becoming midwives. In Louisiana, or in the New Orleans area, there's a shortage, or we have a very low number of midwives. So if a family was deciding to have a home birth, there's very few options for them in our area. And so we wanted to make sure that if families were doing it, they were doing it in a safe manner and that they were aware of the resources that were available to them. Another thing that we decided to do after partnering with midwives, we heard that there was an issue with the collaborative practice agreement. So those of you who may not know, a collaborative practice agreement is a requirement by certain states that either nurse practitioners or nurse midwives have to have an agreement with the OB or physician in order to practice. And there's a lot of limitations because if, say, a nurse practitioner has a relationship or CPA with a physician and that physician were to relocate or to die, unfortunately, then that midwife or nurse practitioner would have to stop practicing. In Louisiana, our governor had a permit, a temporary lift of this CPA. And during this COVID pandemic, the nurse practitioners and midwives are learning or figuring out that that barrier, well, they actually already knew this, but it's actually showing evidence that the CPA, there's no real need for it. that because of state boards of nursing, because of the scope of practice of nurse practitioners and midwives, they are covered to practice within those and not to do anything illegal or anything dangerous. And so we wrote in partnership with different organizations, we wrote a white paper, and we've been utilizing this white paper to advocate on behalf of midwives and nurse practitioners in our area. I mentioned earlier about the policy work that we've been doing to provide, have doulas reimbursed in our area, because many women, if they choose or decide to use a doula, sometimes it's cost prohibitive, or our doulas are providing free services, low-cost services for the community. The last component of what our response, if you recall in the earlier slide, one of the departments within IWES is communications. And we have a huge communication department that really work with us to bring awareness to the community. So during different weeks in Midwifery Week, we had this social media campaign where we were providing information on midwifery care, about the options that are available in our area, and also on home birth, so that people, like I said earlier, would provide, if they choose a home birth, they'll do it in a safe manner. Because one of the things that we're not advocating is that families take their birth in their own hands without the proper education. You have some people doing unassisted births, which is their option, but we want to make sure that if people are choosing to birth at home, that they do it in a safe manner. Next slide, please.
Thinking about becoming a midwife. This is me, you guys. I am thinking about becoming a midwife. Here in the state of Louisiana, there are 2 types of midwife. This lists 3. There are nurse midwives here, and there are certified professional midwives. Certified midwives are only recognized in certain parts of the country, and Louisiana is not one of those places that recognizes certified midwives. But here we have nurse midwives that are only allowed to work in hospitals. They don't work outside of the hospitals. And we have professional midwives who only work at home or in birthing centers. We are not allowed to work in the hospital. So that is one of the barriers that we face, that we aren't allowed to transfer in if we needed care, to transfer a patient, or if we are needing backup, we couldn't officially get it from the nurse midwives in the hospital. But these are the 3 pathways to midwifery. Next slide, please. And here is more of the same. The CNM and CPM are allowed to practice here, and only a few states recognizes CMs. Next slide, please.
So here, midwifery is not always an option. And what we were trying to advocate for is the different pathways, but midwifery care is not for everyone, or midwifery care is not for everyone, nor is the training for everyone. But being a doula is something that, if you think about families historically, how the aunt, the mother, or those who supported the mother when she was going through this vulnerable time of giving birth. And so doula care is something that each family, but I'm completely biased in this, should have someone in their family that is trained to as a doula, so that we can provide the support for our family members and our friends. And I just want to uplift this quote from one of our interviewees. She said that I was in labor for like 25 hours, but because I was at home, I was in labor and had contractions. And I'm gonna stop there. The only thing I really want to highlight is for a woman who is going through 25 hours of labor and may not have the support that's needed, it can be a daunting task, and a task that may cause her to give up on it, and maybe I like to tell my teach in my classes about that psychophysical response. So if you are going through a lot of pain and your body tends to shut down, the baby's heart rate might elevate. And so a doula is there to support her, to help her to alleviate that pain and make it a more comfortable situation for the mom during this time. And during the COVID time, it was important because people could labor at home. Even if a woman decided to birth at a hospital or decides to birth at a hospital, which is a viable option for most people, that doula could help her to labor at home and then go into the hospital birthing with low interventions and then go home. So one of the things that I'm a huge advocate of is that we found in our research that our OBs do not have enough time with their patients. And so midwives and doulas actually help them to relieve some of that burden. Like I said earlier, midwifery care is not for everyone, nor is the training for everyone, but I just really want to shed light on that and the importance of doulas in helping us improve birth outcomes. Because if we think about it, it takes all of us. It takes researchers, it takes OBs, clinicians, policymakers, all of us working together to improve the birth outcomes. Next slide, please.
And here, did you know, I love this slide. A home birth might not be right for you. I stress this to most people that I come across, that most of us are low risk people who are able to birth outside of the hospital, but there are some of us who definitely need to go to a hospital. So here we see different components of what that looks like and what high risk means. Here in the state of Louisiana, you actually need a clearance, so to speak, from an OB to have your baby at home. You have to go one time to see an OB and they give you like an overall checkup at the beginning of your pregnancy or even the middle of your pregnancy. We have people to come into care a little later, and it just says that you don't have high blood pressure or diabetes or anything like that, and that clears you for a home birth. But sometimes because of the scope of midwifery care, if you do have things like high blood pressure, that risk you out from having a home birth, because again, we want to stress the safety of home birth. And sometimes, having high blood pressure or diabetes, or if you have some type of liver failure, which commonly happens during pregnancy, then we want to make sure you're in the best situation and have the best birth outcomes, because that's what midwifery care is about. So, having a home birth might not be right for you. And during COVID, what we saw was a lot of times we would get calls to our office of women being scared. They were scared, their families were afraid, but they knew they didn't want to birth in the hospital. And they didn't even know, oh, I am a viable candidate to have my baby at home, or oh, I'm not a viable candidate to have my baby at home. So it was, I feel like at the beginning of the pandemic, a year ago, it was very interesting to see the balance of who, risked out of midwifery care. Next slide. And this is National Midwifery Week. And May 5th of every year is International Day of the Midwife. I West did a panel this year that I actually got to sit on. It was great. You talked about that a little bit, Sister Michonne, where we all sat on the call and we kind of brainstormed around how do we take down the barriers of becoming a midwife, because it is a daunting task. It is a financial ridden task as well. People tend to think because it's not traditional schooling that, it's not the same financially. It's a lot cheaper, but it is still an expensive thing. And if you're here in like New Orleans or some other places in the country, there are not a lot of midwives that can precept you. So that makes it also more difficult. And those were some challenges that we talked about during National Midwifery Week when we had that awesome panel. We talked about different options. We talked about what midwifery care looks like in the state of Louisiana and more specifically in New Orleans.
And Shay, I just want to add all of these slides with the quotes are pictures of our social media campaign last year that we did as well.
Yes, and I also want to point out a lot of them were my clients. So if you see those beautiful words up there, those people were in my care, and it actually warms my heart a lot to see, somebody that says, I felt safe. I completely trusted my birth team. So that really makes me happy. Yeah.
And yeah, and I like one of the quotes on the earlier slide. It talks about the science that my midwife gave me all the articles and the research. So it's not this kind of witchcraft thing. It's scientific based work. I just wanted to say that because sometimes people think of midwives as this kind of barefoot kind of thing. Next slide, please. And we're going to get ready to wrap up. So here are our recommendations based on the work that we've done in your community. And I can't stress enough, collaboration. Whatever you do in your organization, that is your expertise, but we should not work in silos. And that's something that's really helped us to improve our outcomes or improve the work that we're doing here locally. So improve direct services. And when I talk about direct services, I am talking about those clinical services with the OB and the midwives, making sure that they're providing quality care. I think most states have the perinatal qualitative collaborative. And I know postpartum hemorrhaging is something that hospitals are working on. So yes, improving those medical services, but also those things like systemic racism. It is real. There was an article in the British Medical Journal that talked about babies who were cared for by Black doctors had better outcomes in the NICU than those who were served by white doctors. There's an article that my colleagues and I did in Health in Place that talked about infant mortality and systemic racism. Here locally in Louisiana, last year, there was an implicit bias bill that was passed that healthcare providers and hospitals are now required to do implicit bias training. And that's just the start of what they plan to do, because it does make a difference for the families that we serve. Also, time for OBs. I had one in one interview, a mom said that she really loved her OB, but she had to change because she just didn't have enough time in a visit to see her to build that trusting relationship that she wanted with her care provider. And so she decided to go to a midwife instead. Next thing, provide educational opportunities. Of course, internally within our organizations, we can improve on ourselves. But what's going on in our community? Is the workforce diversified? Meaning, do we have enough OBs? Do we have enough midwives? Like Shay was saying, although we have some certified professional midwives in this area, there's very limited opportunities to train more because we only have a few and they need that apprenticeship. So what kind of schools do we have? Do our nursing schools provide midwifery options? What about physician assistants? So diversifying the workforce so that we have those different tiers so that the OBs are relieved and they can provide great quality care for those who need their help the most. Race and ethnicity is important, as I talked about earlier about the systemic racism, but at times it is good. Some people really want to have someone that looks like them. And so having that option as a option in your community is very important. Policies. I don't know if you all heard about the Black Maternal Omnibus Act that was released. Please look into it. It's a federal policy, and just want to advocate on all of those titles that's listed under there, the different policy. And here in New Orleans, we have our own New Orleans Omnibus, where things like the doula care, the collaborative practice agreement is a part of that, because we really want to advocate for change on a systemic level, as well as on a community level and individual level as well. And I want to close with our last slide. If you want more information, here are our partnering organization. Shay works with the Birthmark Doula Collective in New Orleans Midwives, and this is all of our social media handles. Once again, I work with the Institute of Women in Ethnic Studies, and our final collaborator on this project is National Birth Equity Collaborative that does a lot of birth equity work in our community. And I thank you, and if you have any questions, we're here.
Thank you.
Thank you so much for that presentation. Really appreciate you sharing and making the time to join with us and our members. We have just a few minutes left, so I'll open it straight up to any questions. I will put a plug that we're always collecting information from our members about how your state or territory has utilized funding from Title V to respond to the pandemic, or how could you utilize additional funding. And remember, just feel free to type any questions for any of our presenters into the chat. Our next call will be Thursday, April 1st from 2 to 3 p.m. So make sure to register. You had the option to register for that call as well when you registered for today's call, but just to make sure you have the invitation. And as always, we'll be sending out a copy of all the slides for everybody. So we'll leave it open for another minute or two in case anyone has any follow-up questions for our amazing presenters. And I will add, thank you for mentioning the Black Maternal Health Omnibus. AMCHP is a proud endorser of those bills. We had worked closely with many of the bill sponsors to provide feedback and ideas, and we're really excited about that and love being a part of the effort to get those bills passed, maybe this Congress. All right, well then everyone enjoy the rest of your day. It's beautiful here too, so I'm gonna try to step outside. I hope you can do the same wherever you are, and we'll see you back in a few weeks.
Someone,
Bye.
I'm sorry, someone asked a question that I would like to.
Oh, sorry. Yeah, thank you for pointing. I didn't see that. Okay.
Yeah.
How do doulas and midwives reassess a pregnant woman who may have received clearance from an OB to have a home birth, but may later develop high risk factors during the pregnancy?
So that is a great question, and that's why I couldn't let you skip it. One thing we do in midwifery care is a lot of preventative work. Sometimes when we get a second time mom, they say, in my first pregnancy, I developed preeclampsia or high blood pressure or gestational diabetes. So what we immediately do as providers is start to develop nutrition around preventing those things to happen. Believe it or not, the food that we eat affects us greatly, especially during pregnancy. So that's one of the first things that we do. The second thing that we do, we come up with a shared decision-making plan. So we may say, okay, well, we're gonna work with you up until 36 weeks to see how, you know, this is affecting you, affecting your body, affecting your baby. And if all is going well, then, you know, you'll be clear to have a home birth. And then if not, we will help you, you know, find your OB, your original OB that you work with, or someone in the hospital that can treat your individual situation. But what we like to do is try to prevent those things from diet. It's actually, we joke about it all the time. But it's required here in the state of Louisiana for us to have a diet journal of every single patient that we have in your chart, which is not required for obstetricians. So that's actually very important. So we try to work with your diet to prevent a lot of those things that do come up. And oddly enough, our transfer rate is about 2%, which is extremely low. So we do have a very successful rate in preventing those types of things. So if they do come up, we do have a way to combat them. Yes, that was a great question.
Excellent. Thanks so much, Shay, for flagging it for me. I almost missed it. Great. Okay, well, it's 3:01, so we're going to have to end the call there, but luckily our guests did provide contact info. If not, you can always contact a member of AMCHP to put you directly in touch. Thank you again so much. Hope you all have a great rest of your day. Bye.